Good morning. I'm Kathleen McGarry. I'm a professor of economics at UCLA and one of the MPIs on this project. So I'm pleased to be able to introduce our first research panel of the day, following up on the morning's keynote talk on caregiving. So we're going to have 3 speakers. Each will take about 15 minutes to deliver their remarks, and then we'll open it up to questions from the floor. So as Julie also mentioned this morning, there's detailed biographies of all our speakers on the conference webpage, so you can take a look at that. So I'll be very short in my introduction so we have more time for questions thereafter. But our first speaker is Gopi Shah Goda. Gopi is now a senior fellow at the Brookings Institution, and she is their director of their research security project. Retirement security project. And she was previously a research fellow at CEPR at Stanford. And she is a PI of one of our brand new research awards. So I'll turn it over to Gopi.
Thank you, Kathleen. I'm going to advance the slides. Here we go. And tell you a little bit about a joint project that's actually being worked on under Kathleen's direction, a joint with our other colleagues, Brian McGarry and James Glusman, about an international long-term care project that seeks to understand questions about what we can learn about long-term care systems by standardizing measurement and analysis techniques in a large set of different countries around the world. So I've listed the countries here just to give you a sense of the scope of the project. But the countries that are involved in different rounds may differ from year to year. This whole project is modeled after the successful and long-running project at the NBER called the International Social Security Project, which sought to do the same thing and has been hugely influential in policy discussions related to Social Security. So the first round of the project, which started about 5 years ago, was really thinking about how to summarize the landscape of each country's long-term care insurance and long-term care programs, both about the population dynamics and how changing demographics is changing the landscape for long-term care. What are the different types of programs, both public and private, that people have access to in the space, and how are they funded? The project also, this was mentioned earlier, developed a way to determine the costs of care in a comparable way across countries and divided these costs into different sources of payments and types of care that was paid for. That culminated in an edited volume that summarized some of the findings from each of the individual countries, as well as provided an overview of how different countries compared to one another. In the second round of the project, we've been focused on how care for populations with low cognition changes across these different countries. So I'm going to show you some of the results from the second round. But what we've been focused on is thinking about the prevalence of low cognition, the overlap with the inability to perform various activities of daily living, what care receipt looks like across different populations, and how the population with low cognition compares to other groups. And with some exemptions, we've been using similar sources of data from the health and retirement study and also sister surveys from different countries. And our attempt was to use data prior to the pandemic in sort of the 5-year period prior to the pandemic. But there are, again, some exceptions across different countries based on data availability. So I'm going to tell you a little bit about our findings and really focus on the United States, but then come back to how different countries compare and some of the outcomes that we're measuring. But let me first tell you a little bit about how we're thinking about measuring cognition with our survey data. So one big limitation, or it could be seen as an advantage, is that we're not using dementia diagnoses in across these different settings. What we're using is a source of data that is available in all of these different countries in a fairly comparable way. And those are basically components of the mini mental state examination, which is a 30-point questionnaire that evaluates different aspects of cognition, including orientation, memory, attention, language, and helps clinicians identify potential cognitive impairment and monitor changes in cognition over time. The idea of using this measure of cognition is that we wanted to see develop an absolute threshold for low cognition, and we set that threshold in the US context at a score of 6 or lower out of a possible 29. And the 29 represents a subset of the MMSE that is available in a more comparable way across countries. Okay. So as I mentioned, I want to focus first on the results from the United States and then kind of zoom out a little bit and show you some of the results from the other countries. So the first thing I'm showing here is just the distribution of cognitive scores among people age 65 and older in the health and retirement study in the 2016 and the 2018 waves. And you'll see that there's one bar way to the left that mentions that is labeled as proxy. And that's a really important group to be thinking about when we're thinking about low cognition, because there's a set of respondents in the health and retirement study who don't actually answer all the questions of the survey, but they are answered by a proxy. And one thing that is a benefit in the HRS is that you can also understand why there is a proxy interview being done. And in a lot of cases, those proxy interviews are being done because of cognitive or memory issues. And as you can see that when we set the threshold at 6, and we also mark those who are responding by proxy due to these cognitive limitations, the proxy respondents make up a large share of the population that we are going to be considering as our low cognition group. So in particular, out of the total, about 7% of the sample that is considered to be low cognition, 2/3 of that group is there through proxy. So this next table just shows you a bit about the joint distribution between cognitive scores and ADL limitations. So as you can see from the table, there's a high share of those with low cognition who also have ADL limitations. And about 57% of those with low cognition also have 2 or more ADL limitations. Now, I want to note here that this is not necessarily a clean separation, because the way that the HRS and a lot of different surveys ask about activities of daily living limitations is, please tell us if you have any difficulty with various activities because of a physical, mental, emotional, or memory problem. So it could be, it's not the case that these ADL limitations necessarily represent, physical impairments as opposed to cognitive impairments, because it could be that these activities are not able to be performed because of the memory issues themselves, which makes sense when you see then that big overlap in ADL limitations and low cognition. So I've color-coded these slightly just to show you that we're going to be combining the group with low cognition in the red and compare them to those in the yellow who have physical, these ADL limitations, but have cognitive scores that are above the threshold that we're using. And the green group, which is thankfully most of the sample, about 85%, are people who don't either have low cognition and also have at most one activity of daily living limitation. Okay, so this is sort of one of our key findings where we break up the care utilization in terms of costs, both in the aggregate and also per capita across these 3 different groups. And I know there's a lot of numbers here on the page, but I just want to highlight a few of the key results from this figure. So one is, you'll note that on the bottom, the population of those with low cognition is actually smaller than the population of those with 2 or more ADL limitations with higher cognitive scores. And however, if you look just above that, the aggregate costs for the low cognition group are much higher than the aggregate costs for those with only ADL limitations. And this is this has to be true because the per capita costs of care for those with low levels of cognition is just many times more than the per capita cost for those with ADL limitations only. And you can see if you look further up the table that a lot of this is driven by differences in the costs of nursing homes. And it kind of points to some of the features of this low cognition population are that the 24-hour need for care often results in the care recipient being placed in a nursing home or requiring very costly home care provided around the clock. Okay, in the interest of time, I'm going to skip this slide and move to just tell you a little bit about what we find in the other countries. So what I've shown here is basically some of the key findings for the United States on the left as compared to 4 other countries that were part of our big project. And the reason I picked these 4 at the moment is because these 4 rely on survey data sources that include more comprehensive information about nursing homes than some of our other countries in our study. So England, Spain, Denmark, and Singapore primarily rely on survey data sources that include some ability to follow people when they move to nursing homes. Okay, so when you look at the left set of bars, you basically see what I was telling you before about the United States, which is the population shares for the group with ADLs only is actually higher than the population share of those with low levels of cognition. That is not always true in all of the different countries that we look at. Sometimes the population shares vary, and this could be because of different levels of prevalence. It could also sometimes be because countries chose slightly different thresholds in terms of their cutoffs for what they chose as low cognition for some reason or another. Now, if we look at the spending, you see very similar patterns as we saw in the United States, where per capita costs for those with low cognition are much higher than per capita costs for those with ADLs only. You see that same pattern occurring in England. However, you see a reversal of that in some of the other countries. So it's not a universal feature of all of the countries in our sample. So I hope that gives you just a little bit of a flavor of what we've done with the International Long-Term Care Project so far. There's more to be done in this space going forward, but this is where we're at with the project at the moment. So thank you.
Thank you. So our second presenter is Kate Miller. Kate is an assistant professor of health policy and management at Johns Hopkins University, and she's also a co-investigator of one of the founding R01s for the coordinating center that's focusing on strengthening the dementia care workforce.
Hi, good morning. Thank you all so much for coming and for the chance to be here today to share with you all a project that I've been working on in collaboration with Dr. Lane and Dr. Coe, in which we examined the effects of a policy that made home healthcare workers eligible for minimum wage and overtime protections. And so specifically, we want to understand how this policy did or did not improve labor force stability, and then how it did or did not improve the economic outcomes for the workers themselves. So we know that workforce conditions like scheduling volatility, hours worked, adequate training for the tasks required, as well as opportunities for professional advancement, job satisfaction, and compensation are all contributing factors to labor force stability, specifically thinking about retention and recruitment. Unfortunately, many home health care aides and personal care aides in the home health care industry have poor working conditions, and this workforce is disproportionately female and disproportionately women of color who have low levels of education. We know from theory that, of course, increasing any of these components should decrease turnover and improve worker expertise and productivity, but it's also not always cost effective for an employer to make those changes. They need to balance the cost per employee versus the cost associated with worker turnover in order to maximize their profits. And if workers don't need specialized training or are perceived as not difficult to replace, lower wages may be optimal from the employer perspective. But in the healthcare industry, there are additional considerations, such as the potential impact of turnover on patient outcomes. And worker turnover is associated with lower quality of care and worse patient outcomes in both the home care and the nursing home setting. And one of the most common policies to increase compensation is through the setting of a minimum wage. And we know that by setting the minimum wage higher than the federal rate, this should increase worker wages, reduce turnover, and thereby improve worker economic status. But we also know that firms may want to offset the higher labor costs by decreasing the hours worked or shifting full-time workers to part-time work, and this can have potential unintended consequences. It's important to note that firms may also seek to substitute labor with technology. This is important to note, but in the context of home health care, this is arguably less likely to occur given the hands-on nature that a lot of these individuals provide. When we think about the mechanisms by which the overtime protections can impact workers, in theory, this should increase their earnings and improve their economic status. But again, firms may try to offset the labor costs by reducing the opportunities to work overtime hours or reducing wages. And a review of the literature shows that, of course, minimum wage increases result in higher weekly earnings for low-wage workers, fewer layoffs, separations, and turnover rates, and the negative employment effects observed seem to be largely driven by reduced hiring. With regards to the overtime protections, the evidence suggests that overtime protections will reduce hours, but also reduce wage rates, but the total effect on income is ambiguous. And so in 2015, home care workers became eligible for minimum wage and overtime protections under federal policy. For the first 6 months of 2015, this rule was not enforced. And then for the latter half of 2015, it was somewhat enforced. There was prosecutorial discrimination for the Department of Labor. So beginning in January 1, 2016, it was systematically enforced. So our research objective is to understand how this policy change impacted turnover rates and percent of stable workers, and then also to look at the distribution of hours worked by individuals and how this policy may or may not have impacted their income and earnings. We hypothesized that it would improve workforce stability, and the expected net effect on individual economic outcomes was ambiguous. And I just want to note that just as states can set minimum wages above the federal rate, states can also opt to extend protections to workers. And in fact, that's what we saw. Prior to 2015, a handful of states had already extended minimum wage and or overtime protections to this workforce. And so to further understand these policy impacts, we do a heterogeneity analysis to understand whether or not we still observed an effect from the change in the federal policy among the states with and without these pre-existing protections. So we use 3 primary data sources. First, we use the quality workforce indicator data, which exists at the county level for specific industries, and then you impute by sex and across different levels of education to identify your desired sample. We also use the area health resource file to capture county level demographic and economic characteristics. And then finally, we use the American Community Survey to examine the worker level outcomes. So for our sample, our treatment group includes women with a high school level of education working in the home healthcare industry. By focusing on these individuals, we are really honing in on the population most likely to be home healthcare aides and personal care aides who are going to be impacted by this policy change. For our comparison group, we know that there is no perfect comparison group. And so what we do is we use multiple comparison groups and go through an exercise to bound our estimated policy effects. So first, we identify workers with a high school level of education working in the animal slaughtering processing industry as our upper bound estimate. There are very low job-to-job transfer flows between home healthcare workers and workers in this industry. For our lower bound estimate effect, we also look at workers in child daycare service industry. There are some job-to-job transfer flows between home healthcare workers and this workforce. They're much more similar with regards to their demographic characteristics. We also explored using women working in skilled nursing facilities. However, there is extremely high job-to-job transfer flows between those two industries. So we thought that would really dilute the potential policy effects. And we also checked empirically, and there was evidence of violation of pre-trends. And since we are using an event study difference in difference approach, we exclude that comparison group. In the interest of time, I'm only discussing these two, but we do explore other low-wage industries that I'm happy to talk about in greater detail. As I mentioned, we use an event study difference in difference approach. We use multivariable ordinary least squares regression with standard errors clustered at the state level. And in addition to looking, obviously, at the coefficients in the pre-period, when thinking about our assumption of parallel trends, no violations of parallel trends in the pre-period, we also conducted the test for power to ensure that we had sufficient power to detect violations, and we found that we had no cause for concern there. When looking at our empirical strategy for our worker level outcomes, we do a very similar model. Our specification is slightly different, and this is largely driven by a smaller sample size. So moving on to our results. So compared to our treatment group, our comparison group has slightly lower percent of Medicare Advantage penetration and percent of population age 65 and older. The treatment and comparison groups have similar unemployment rates, and the comparison sample has a slightly higher percent of persons in poverty and adults without health insurance. So these are the model-adjusted predictive values of the turnover rates among home healthcare workers and from our two comparison groups. As a reminder, 2015 is when the protections were extended to home healthcare workers, and it was systematically enforced in 2016 onwards. And we see similar predicted values for the home healthcare industry and both our comparison groups in years 2013, 14, and 15, and then the subsequent years really diverge. On the left here, we're looking at the quarterly turnover rates, and on the right, we have the percent of stable workers. These are just two slightly different measures to try to get at labor force stability. Ultimately, what we find is that the policy change decreased turnover by 3.5% when comparing home healthcare workers to child daycare workers, and it decreased turnover by nearly 17% when comparing to the animal slaughtering processing industry workers. And we also find confirmatory results when looking at the percent of stable workers. I just want to note that percent of stable workers higher indicates greater stability, whereas yes, and so we do see that improved stability here. For our heterogeneity analysis, we find evidence in support of our a priori hypotheses. We find no evidence of an effect of this federal policy change among the states that already had existing protections for this workforce. And we do find evidence of an effect among the states that did not previously have these protections. We do a lot of robustness and falsification analyses, and in the interest of time, I won't go through all of them other than to say we look at not only falsification tests among and between our comparison groups, we use additional comparison groups and alternative specifications, including synthetic difference and difference. We also look at heterogeneity by whether or not a state expanded Medicaid or not. And in summary, all our analyses really tell the same story, that this policy did have an effect on improving labor force stability. Moving on to the worker outcomes, we see that the policy change decreased the probability of working overtime, and it decreased adjusted income among our workers. This was also consistent across numerous heterogeneity analyses, a subset of which are shown here, and I'm happy to discuss in greater detail the additional models that we ran. One thing that I do want to note in particular is that when we looked at the differences by whether or not a state had expanded Medicaid, while we don't find significant effects, it was notable that wages were consistently higher in the states that did expand Medicaid, and that was really true throughout our study period. So where does that leave us? So our key finding is really that extending minimum wage and overtime protections reduce turnover among low-wage female workers in the home healthcare industry, and that this was true across numerous specifications. And this analysis has implications when we consider the costs incurred to employers due to turnover, thinking about the direct care workers themselves, especially given the large share of this workforce that relies on other social safety net programs. And these findings are particularly relevant as the United States population ages and demand for long-term care providers, such as home health care workers, is expected to increase. The COVID-19 pandemic really highlighted the challenges facing this workforce, and in the wake of the pandemic, understanding what policy levers are available to us to help strengthen this workforce will be really critical moving forward to ensure that the care needs of the population are met. Thank you.
Thank you. Our final speaker is Yulya Truskinovsky. She's an associate professor at Syracuse University and one of the co-PIs on our new research awards.
Is this intuitive? Oh. Okay, great. Thank you so much for having this paper. I'm very excited to be here. I want to acknowledge my co-authors, Oner Altendag and Yain Grev. And we are looking at family spillovers of ADRD. We also want to acknowledge the Head Center at Johns Hopkins for some pilot funding. Thank you very much. Okay, so I'm going to skip my motivation slide. I don't think I have to convince you that looking at the effect of dementia on families is both important but also hard. So that's my motivation. I'm going to skip straight to the research question here, which is to try to estimate the impact of ADRD on adult children as kind of holistically as we can, given the data limitations that we inevitably have. So in terms of impacts, we can look at health outcomes, both physical and mental health, and then also labor market outcomes. And then where we do see spillovers, we're going to try and think about underlying mechanisms. So what's driving this? Our approach here is going to be, given that we have fantastic administrative data, not from the US, we are going to link children to their parents via population registries, and we're going to track those children up to 10 years before and 7 years after the ADRD-related death of their parent. And so you have a parent dies with ADRD. What does your life look like 10 years before to 7 years after? I'm going to talk a little bit more about this, but we identify ADRD status based on ICD codes. And we think with this 10-year kind of look back period, we're able to capture really sort of this accelerating period of accelerating care needs and increasing dependency. And then we're also able to see kind of what happens after a parent dies and if there's any post-death recovery, reversion. And we are using an event study approach. And so we're going to cycle through a couple of different comparison groups to try to dig into mechanisms. So in terms of context, right, we're in Denmark. So everything you know about long-term care in the US, forget it, move to Denmark, everything is terrific, very generous funding for public long-term care. The focus is on home-based care. So, you know, people come to your home all the time. It's free. You can move to a nursing home anytime. It's free. I mean, I'm exaggerating, but, you know, it's really the Shangri-La in terms of what exists in the world for long-term care. Couple that with very robust support for family caregivers, including generous paid leave, including programs that'll pay you to take care of your terminally ill parents, including universal health care for everybody. So, you know, when we're thinking about kind of international comparisons, this is a setting where, you know, everything that maybe we want to try to get in the US, like this is where we'll get to. Okay, so in terms of empirical design, this is hopefully you can see this. So we're going to center, as I said, our study around a parent's death. So that little blue dot is the parent death. It happens in year 0. And then the red line is those 10 years before the death. We think we're capturing both sort of a very mild or preclinical period where we don't think that there will be many, if any, spillovers. As we get closer to the red to the blue dot, right? Increasing symptoms, increasing spillovers. We know that ADRD is both progressive and irreversible, right? So we expect things to get worse as we get closer to death. And then in the post-death recovery, where we have 7 years of follow-up. Okay, so our main group of interest here is going to be child-parent pairs where one parent died with an ADRD diagnosis between 2005 and 2011. We have 3, in order to fall in this bucket, your parent has to be tagged in one of 3 ways. 1, ADRD is indicated on a death certificate. This is all using ICD codes. 2, we observe them with a minimum of 2 anti-dementia medications from the National Prescription Registries in the 15 years prior to their death. Or 3, we have ADRD listed as a, I said that in the wrong order, we have ADRD is indicated in either inpatient or outpatient records, right? So in one of those 3 ways, you get into our sample. I'm going to skip the second treatment group for a second. I'm going to go to our placebo control. So we take those parent-child pairs and we match them with parent-child pairs that look very, very similar on observables. However, the parent does not die in that index year 0. So they can die over the course of those 18 years. It's very hard to find people in our sample whose parents don't actually die, right, in those 18 years, but they don't have dementia and they don't die in that year 0. Now, the other thing that happens when you have a parent who dies with ADRD is you have a parent who dies, right? And so there could be that effect of death that is independent of or on top of the dementia effect. So in order to kind of to untangle that, we're going to have a second treatment group. Our second treatment group consists of child-parent pairs where one parent dies in that year 0, right? But they don't meet our criteria for being in the ADRD group, right? Now here you can imagine, you know, prolonged periods of illness where you need caregiving, like just cancer, right? You can imagine sudden death. We don't untangle that. This is just anybody who died for any other reason. And those parent-child pairs are matched with their own placebo controls. We do a very good job matching. That's the only thing this slide is trying to tell you. And the average age of children in our sample is late 40s, early 50s, right? So think about that's the age where they experience a parent death. Okay, so let me jump to the results. I'm going to show you primarily unadjusted trends, right, rather than regression results, because we think that the unadjusted trends really speak for themselves. So I'm starting with labor market outcomes. I have 4 outcomes here: labor force participation, the top left, employment, bottom left, wage income, and labor income. That vertical dashed line that hopefully you can see is that year 0 when children whose parents have ADRD, I'm going to call them ADRD children. If you have better nomenclature, please come at me. So the ADRD children experience that parent's death. Those are going to be the black diamonds. The red circles are going to be that control group. They do not experience a parent's death in year 0. It might be hard to see which group is which because they are directly on top of each other. So not only do we have very, very nice pretrends, but we also have absolutely no impact, observable impact whatsoever on labor market outcomes. We've looked at a bunch of different outcomes. We don't really see much. Again, these are completely unadjusted. I'm not going to show you the regression results because they're boring, right? We next look at physical health. This is just 4 of the many outcomes that we've thought about. I've got PCP, specialist visit, outpatient hospital visit, or a preventative exam. Again, same story. The vertical line is that death year. The black diamonds, the black circles, excuse me, are the children who do not experience, who do experience a parent's death with ADRD in year 0. The red circle, the red diamonds are the matched controls. Once again, we have very nice pretrends and very little in the way of changes in physical healthcare use around the time of death. So our third set of outcomes is mental health. Okay, here things look a little bit different. So again, same setup. Now you can see that we have A, very nice pretrends, we think, but B, you see a lot of an increase in mental health care use among children whose parents die with ADRD well before that death. So I should have said this earlier, we're looking at everything separately by gender, and I apologize for not emphasizing that earlier. We have men on the left and then and women on the right. The top outcome is a mental health visit for any to any kind of provider, and the bottom is use of psychotropic medications. That includes anxiety, depression, sleep medication, as well as antipsychotics. So you can see both a large increase in mental health care use right around the time of a parent's death, but also a ramping up that happens well before, in particular for women. So it looks like women start to seek mental health care at a higher rate, about 5 or so years before their parent dies. We have regression results that can help us to get at effect sizes. I'm gonna skip this for the interest of time. I'm also gonna skip the breakdown by visit type and medication in the interest of time. I will tell you that we've done a number of different subgroups. The effects seem to be concentrated among children who lose their parents early in life, so children who are younger than 50. We've looked by sibling status, and we see some evidence that only children experience larger effects, in particular in use of psychotropics, but not much in terms of parent partnership status, right? So we're thinking about subgroups that might have greater caregiving needs because of the availability of other caregivers, etc. Okay, now, of course, the thing that's happening, as I mentioned before, in year 0 is not only that you have a parent who has ADRD who dies, but also that you just have a parent who dies, right? And that in itself can be stressful. So we do this exercise where we're taking that second treatment group, and we're seeing what happens to everybody else who loses a parent. And here I've changed the colors on you a little bit. So the red is going to be those children who lose a parent for any other reason in year 0. And the blue is now that match control group who don't lose a parent in year 0, but can lose a parent at any other point in the trajectory. And you can see that similar to the results for the ADRD children, we see these large spikes in year 0. So indeed, losing a parent is stressful. Grief increases the likelihood that people use mental health care. But we don't see that pre-death ramp up that starts about 5 years before. So I've got here the ADRD sample just for comparison. Right? You can see that these trends really do look quite different. And when we throw in all the fixed effects and controls and cluster all the standard errors the right way, we hope there are clear differences between the ADRD sample and just simply losing a parent. Okay, so we find that parents, having a parent with ADRD leads to increased mental health care use, in particular among daughters. Sons show a similar pattern. I didn't dwell much on the gender differences. Men have a lower baseline of using mental health care, right? And the effects seem a bit small or look much smaller for them. We see that these effects emerge 2 to 4 years before a parent's death, and they persist. We don't see any substantial effects on labor market outcomes or physical health outcomes, right? So this can't be explained by health-seeking behavior and just in general, and we don't see people withdrawing from the labor market suggesting that they're taking on significant caregiving roles. And parental loss, just simply losing a parent, seems to contribute to some of the effect, but it does not fully explain it. So we really think that having a parent with dementia is driving a lot of those the mental health care use that we see. Okay, so the big question here, of course, is there caregiving going on, right? A lot of the literature that thinks about spillovers on family members focuses on caregivers, right? If you are taking care of your parent, you know, what happens to your mental health? And when we think about care, we're thinking about that hands-on help with ADLs, IADLs. In this case, we don't know, right? We have administrative data. We can't say anything about caregiving. We have some survey results. Members of our team have put a survey in the field. We see limited caregiving in this context among children. Children are not spending a ton of time taking care of their parents. We think here we want to emphasize that non-caregiving channels can also be really important. So a lot of the kind of emotional effects that Courtney mentioned in her talk, a lot of the, you know, having a parent whose personality is changing, who's difficult to manage. There's a lot of spillovers that go beyond just the direct caregiving role that we think are playing a role here. And so while kind of previously found labor market impacts spillovers to children we think can be mitigated, we think they're being mitigated in this case by this, you know, robust social welfare state and access to publicly funded formal care. These substantial mental health spillovers persist even in this context. So, you know, this is something that's important to consider. We can't really formal care away some of the effects. So we have to think about how to manage this a little bit differently. Just as a small preview, we do have a companion paper where we're going to look at spouses. So stay tuned. Thank you.